So we've been talking about things we hate.
Talking about things we
All right,
hate.
I want to hear a term that you hate.
I hate the term air hunger. The patient's air hungry. What do you think about the term air hunger?
Air hunger. I think first off, we should normalize the term air hangry because that makes more sense to me.
Sure,
I can get behind air hangry.
Yeah.
You and I are in a diet competition right now.
We are.
And
I'm hungry for more than air.
And I'm hangry almost all the time. So
sure.
I can get behind the hangry term. Air hunger, I think people probably are saying this patient looks uncomfortable.
Sure.
Maybe they're using accessory muscles.
Sure.
But not necessarily an extremis.
Here's what I think air hunger means. I think air hunger means I want to put the patient on oxygen even though I don't have a good indication for it. So I'm going to say they're air hungry and put them on unnecessary oxygen.
Well, that's a quick dispo.
And that's why I hate it. I hate the term air hungry.
We should talk about it.
Let's talk about air hungry.
Roll the intro.
Roll the intro.
All right, so we're talking about things Steve hates.
Things Steve hates.
Steve hates
I'm Steve.
air hunger.
Air hunger. I hate the term air hunger.
All right.
Because it's an excuse to put normoxemic patients on supplemental oxygen, which can cause harm.
So I know you read occasionally.
Very occasionally.
So I bet you've read a paper that reaffirms your bias on air hunger in normoxemic patients.
I did read a paper. So it was a paper on high flow nasal cannula, which is an interest of mine, right? And they looked at cancer patients who were short of breath. They used a modified Borg score, which is just kind of like
Remind me about the Borg score.
Absolutely. So the Borg score is a subjective scale that they give patients to rank how short of breath they are, right? And it goes from 0 to 10. And at 4 is when you start getting into mildly to severely, getting more severe short of breath, starting at 4.
So it's like a Fauci faces score of doing COVID updates,
yes,
right?
Yes, absolutely. Like this is 10. And yeah. Absolutely. So they use modified Borg score. They got cancer patients that were in respiratory distress. But what's unique about this paper is nobody was hypoxic. In order to be eligible for this paper, for this study, you had to have an O2 sat of greater than 90%. So really, there's not an indication for supplemental oxygen in these patients.
Gotcha.
And so what they did is a 4x4 crossover study. They would do a round on high flow nasal cannula with supplemental oxygen, high flow nasal cannula with just room air, a low flow nasal cannula with oxygen, and a low flow nasal cannula that was just room air, no supplemental oxygen.
Two questions.
So
first, is this like all comers with cancer? Is this like solid organ tumors or lymphoma, leukemia, or just everybody?
Not a huge sample size. So they just kind of lumped all the cancers together. They didn't really differentiate out the different types of cancer.
Okay, gotcha. And then number two. So you said high flow.
High flow.
What does high flow mean? Is that 10 liters, 15 liters, 20 liters, 60 liters?
Sure. So they would start them on 20 liters per minute, but they would titrate up the flow up to 60 liters per minute to kind of treat their shortness of breath or their air hunger.
So basically like to the Borg score, trying to get them more comfortable.
Right. If they weren't getting comfortable,
but not to like a PaO2 or a saturation goal.
Totally based on comfort. And it's really interesting what they found. So when they looked at the high flow nasal cannula versus the low flow nasal cannulas, the patients that were put on high flow nasal cannula got better. Their shortness of breath improved. Their air hunger improved. It got better.
They weren't hangry anymore.
They improved the same way, whether there was supplemental oxygen with it or whether it was just room air. But we know that unnecessary oxygen can potentially be harmful. So if you don't need it,
absolutely,
just put them on room air. So, I mean, this is a great intervention, right? If we had a pharmacology treatment, pharmacologic treatment that improved respiratory distress in cancer patients, we'd be all over it, right? Well, here is a therapy that we can provide our patients that are in respiratory distress to make them feel better.
All right, so you've convinced me.
Yes.
Now tell me who should...
It's like the Tiger Woods. Tiger Woods like that. Sorry. Tiger Woods was the pump. Okay, sorry. Okay, I convinced you. I convinced you on one.
All right, you convinced me. Tell me who are the patients that I should be implementing room air high flow on, because I'm going to have to do some convincing here. This is a little different than when we're usually setting up high flow. So tell me what kind of patients benefit from this.
Sure. So, these were cancer patients, and, there was the paper in Annals of Emergency Medicine that looked at cancer patients that were hypoxic and looked at the palliative results of high flow nasal cannula. So I think absolutely in a palliative case, high flow nasal cannula, if they're distressed, sure, put them on that. Additionally, what else I like is, this is a temporizing measure. This is just making them feel better, but you still need to find the root of why they're air hungry, why they have respiratory distress, right?
Sure.
Is this
they're cancer patients, so they could have a pulmonary embolism. They could be anemic, pancytopenic, so lots of other reasons.
Metabolic derangement, metabolic acidosis. So this is not an end. This is not a destination. This is just something to make them feel better while we further investigate their air hunger and treat the underlying cause.
So are you starting these patients, I'm going to push you on this. Are you starting them are you saying, I want respiratory in here, we're going to start this patient on a high flow, 40 liters or 20 liters,
sure,
21%. Are you starting at something like 40 and 40 and then titrating down to room air as able, or what are you doing?
If they're not hypoxic to start with, they didn't need supplemental oxygen when they were breathing with nothing.
Sure.
So why would they need supplemental oxygen with this device? So I start them at room air. If they're normoxemic, I start them at room air. And then I kind of gauge their comfort level with the high flow nasal cannula, because when you blast 60 liters a minute in the nose without warning, it can freak a patient out. So I start lower and see how they're tolerating it. If they immediately feel better, I may crank it up some. And if they're struggling a little bit, I may leave it at 20. But I just kind of go with how the patient feels. And if I'm making them better, I give them more. And if I'm making them more agitated or they don't like it, then at that point, I'll titrate down or even take it off.
Well, you've taught me something.
Yes.
I work the next 3 days, so I'm excited to maybe put somebody on high flow room air nasal cannula.
High flow room air nasal cannula.
For air hunger.
It'll make them feel better.